So we're going to go ahead and get started with the panel presentation. And we've asked each of our 5 panelists to answer this question. What are the top 3 things you want the audience to know based on your experience and role in the healthcare system regarding advance directives in the most form? And we feel incredibly proud that because of our collaborative effort, that we have a representation really not only from across the levels of care, but from different institutions. We have Front Range Geriatrics represented through Rebecca Jackson, Banner represented through Angela Mills, Poudre Valley Hospital and UC Health represented by Dr. Weideman and Ted Beckman and Katie Fundalinsky. And so before I get started kind of going into a little more detail about each of these individuals, I just wanted to say one important thing about we want this community to have common language, and when there's a question that comes up, that we want to be a community where we continue to work at, instead of saying, look what they did, they don't have the best interest of this person at heart. Instead say, wow, this thing happened. How can we reach out to them and work together to make this better? And that's why we have this great panel here, is because that's what we've begun to do in our community even more. So our first, who doesn't want to go first, which is fine. Sorry, sometimes I tell too much information.
I can do it.
No, I'm just going to, I'll go in order and then I'll let you guys decide. But Dr. Angela Mills, she's the medical director and care coordination at Banner Northern, and she's super passionate about people having this conversation. And I had the opportunity to meet Dr. Mills not only through the Sharing the Care campaign, but also through her participation with Systems of Care Initiative, which is Dr. Jan Wagner's nonprofit group. And so she's an amazing advocate and a hospitalist in our northern Colorado area. And then Dr. Eric Weideman, he is the medical director of the emergency department at Poudre Valley Hospital. And I met him through our work on the ethics committee at Poudre Valley Hospital. And man, when he speaks, he's so passionate and open and honest, and I think his presence in this discussion is a powerful representation of the most form is often where these forms are getting used and reflected upon. And so for him to be able to come here and kind of represent that is a great opportunity for our community to have him be part of this. And then Dr. Rebecca Jackson, like she said, she does these conversations every day. And I also met her through Sharing the Care campaign and when she was working at Associates in Family Medicine. And now I know she sees people that are chronically and seriously ill in our community, in the long-term care community. And she had been part of our UC Health, doing her residency at Family Medicine Center with Dr. Birmingham, and he's sort of an icon in our community as well. And so just how I say some of this, because it's not a typical introduction, but how connected we are as a community. And then Ted Beckman, I don't remember when we met because I feel like I met him without knowing it when he used to come possibly to the nursing homes when he was making people laugh when they're leaving the building. But he's been he's a kind of person that says yes to opportunities. He said yes to opportunities for us to come and talk about the advance directives to his EMS community. He's the Chief of Emergency Medical Services at Poudre Valley Hospital. So he represents the voice of the important work of our emergency medical community. And then Katie Fundalinsky is one of the members of the palliative care team at UC Health, works both at Medical Center of the Rockies and PVH, and we get to work together on a daily basis, and she's an amazing advocate for this work. So whoever would like to go first, the format is they each answer these questions, get about 10 minutes, and then remember to write your questions down. because we'll have a mic going around, and then after they're done, we'll have a chance to answer as many questions as we can.
So I nominated myself to start just because of where this all starts in pre-hospital care, and that's where we operate in the pre-hospital environment. So what I wanted to, the top 3 things that I wanted everyone to know kind of leads us through a path of what EMS and paramedicine was and what it is going to be. So what it was is, you throw somebody in the back of the ambulance and you get to the hospital as soon as you can, regardless of advance directives or patient type and condition or specialty hospitals or anything like that. That's all we used to do. And some of the training is still like that, unfortunately, where we get on scene and we are trained to make people survive. We're trained to not watch and let someone suffer. We're trained to help them put oxygen in their lungs and medications in their veins and make them feel better. That's what we're trained to do. So in this environment, we do have to kind of take a pause and reflect on if there is an advance directive and what does that look like. And so that advancing into kind of what we are today is that advanced, an essential service in healthcare and providing a safety net for a lot of individuals that need some kind of influence with healthcare and the healthcare industry. And because of that, our training, our education, and our standards have increased to reflect that. So much so that we are comfortable now with waiting on scene and delivering multiple milligrams of morphine to someone who's uncomfortable and making sure that they are okay, to the point of that we are trained to incorporate and integrate with hospice and social work and make sure that they are there as well and the family understands why we are waiting on scene and not transporting someone to the hospital, which once again, it goes against conventional wisdom because as our industry changes, it changes from what used to be and where we're going in the future. So the other big thing is, we will honor most forms or advance directives when they're valid, when they're complete. The hesitancy from our crews come from when there's something missing, a date, a doctor's signature, a patient signature, something like that. But if they're complete and they're on scene, we will completely honor those directives, and we do not have to transport them to the hospital. We'll leave them on scene or whatever their wishes are. The other thing I want people to know is that we have a little saying like "do not resuscitate" does not mean do not treat. So if someone's heart has stopped, we will not try to restart it. But if they are having difficulty breathing because they have some wheezing, we're going to give them albuterol. If they have pain, we're going to give them morphine. We're going to treat their symptoms so they are comfortable. We're going to give them oxygen and make them as comfortable as possible. The other thing I'll mention is our community paramedic program is going into looking into some different phases. One of those is a partnership with hospice. And the way that would work is if a 911 call is initiated and the patient is registered with a hospice organization, then our team would be dispatched and a specialty care provider would be there that would have the best interest of the hospice agencies, and be that mediator until that hospice nurse can arrive on scene. So that's something we're looking at, like I said, from past what we used to do to future what we're doing now. And as far as advanced directives go, that's where we're at. So thank you.
So now we go to the ED?
That's right.
All right. So thank you, everybody, for coming, and thank you for that introduction. It kind of stinks to know that I'm such a good speaker when I like to set the bar very low and then just kind of build on that, so I'll give it a shot. But when asked to kind of talk about the top 3 things from the emergency department standpoint, it's tough because the reality of it is that by the time you get to the emergency department, a lot of things happen very quickly. And especially if someone is in distress, we can do some amazing things. Sometimes those are appropriate and sometimes those aren't. The biggest thing take home from discussions that we've had prior to this and here is that the importance of that conversation prior to getting there is the key. And it's not just filling out a form. It is, and I'm sorry if I've taken away from lectures that you've had before, it's that conversations with family members. It's the conversations with, we refer to them as patients, but they're the people as well, because nothing is more frustrating from a physician standpoint, from a EMS standpoint, from any care provider, and also the family, when you have all this stuff done and Aunt Betty or Uncle Jake show up and say, hell no, we're doing something different. And all that does is add to the turmoil and obviously the very stressful situation that you're already in. So the importance of this conversation prior to even getting to EMS or the emergency department, I think is key in moving this forward. Once you're in the emergency department, it can be a very eye-opening experience. When you're talking about most forms and DNRs, usually the ED are the jerks. I told myself I wouldn't cuss, but the jerks that don't honor them or just keep pushing through, or we did that to your mom or your dad and they never wanted that. To Ted's point, we are always looking to help somebody. And so if we don't have that information up front and in front of us, we are going to decide to do something. Now, there is the reality of futility. There is the reality of maturity. What will work won't work. In the handouts, you can see the survival rate of CPR is pretty darn low. Most young, healthy people have about a 15% chance of surviving an out-of-hospital cardiac arrest. That's young, healthy. Those numbers drop dramatically with any sort of comorbidities, maturity, all that stuff plays into it. So CPR and those sort of things, once you get to that level, your survival rate's pretty low. And anybody that is seen that, it can be a very eye-opening experience. It can be, some people describe it as a violent experience. I guess in some ways it is. In our world, it's procedures that we're doing to kind of keep the sustaining life, if you will. It's not a bad thing, but if you're not used to it or have never seen it before, it can be very traumatizing. So I apologize for that, but it is something that we do and we take very seriously. Yeah, I don't know. I want to talk. I got a hospitalist down here and everybody else. That a lot of times these conversations turn into, all right, the ED sucks, and you guys. So I'm watching my words of how I describe this.
We're at opposite ends of the table.
Exactly, for good reason. But no, it is something that needs to be talked about. And here's the reality: is that if you have a loved one or family member and you know that they're sick. If you've never seen them start to die or go into distress, it's very difficult for anybody facing that down as a loved one to make that decision, and that's what we're here for. The reality of it is that it's okay to call 911. It's okay to come to the emergency department if you don't know, but the key is just educating yourself and your family members of exactly what this means. But anyway, I'll give it to Angela. You can crap on the ED all you want.
Thank you. First, I just want to say thank you for being here. This is a very important topic, so really appreciate your presence here today. And Peggy deserves a lot of credit for all the work that has gone into this, and to have all of us from different areas, different systems working together for this topic, so thank you. I love hearing the perspectives thus far. As a hospitalist, I would take a patient from the ER, and what I have that these two don't is time. And so for me, the most form is something that is definitely I would go to in taking care of any patient who is at that stage in their life with chronic severe illnesses, or when I realize that this is now the third or fourth time the patient has been hospitalized within the last 6 months, which is why palliative care is so important as well. The three things that, for me, this form, when I look at it, because I look at it often, one is that this is just a guide. I think that when people start filling it out or you bring it up to a patient or a family member, there's a lot of fear with this form because it seems like you might be signing your life away. And I don't understand that fear. So if we can try to break down that barrier, that this is permanent, set in stone, whatever you put on this form right now today and it's signed is the end all, is not what I see as a hospitalist when I'm seeing patients. I have two roles within the organization. I see patients as a hospitalist, and I'm also medical director of care coordination. What I will say is with the time and going over this and looking at it with a patient, knowing that it's a guide, I can sit down and usually have that family meeting, talk to the patient about what's written, and go over it as needed. I'm not usually in the situation that Ted's in where the patient has no capacity if there's trauma or if something's going on. I'm usually in the situation where a patient does have capacity and we can go through this or talk about it just so I know that we're on the same page. I'll give you an example of how this may or may not be permanent. Someone who has end-stage cancer who has filled this out and they're young, they might have stage 4 breast cancer, and they've selected that they want to do CPR, they want to be full treatment, they want artificial nutrition, everything has been filled out, it's signed medical durable power of attorney, and maybe something has happened, whether it's related to their illness or a different illness that they have. They went through the ED, maybe they needed CPR, and now I'm taking care of them. Or maybe they didn't need CPR, but now I have them under my care, and they've been in the hospital so many times recently that we're seeing that their prognosis is getting worse. We're having to do more things with that patient. And that same patient who filled this out, within 6 months might be having more discussions with myself, other team players, social work, case management, their own family, and deciding that, I don't choose that anymore. I don't want this anymore. Maybe I don't want to come back to the hospital anymore. Maybe I still want treatment, but just not emergent treatment. I loved one thing that Ted said, is I think one of the fears with this too is that when you fill it out that you're no longer going to get treatment. It stops. That is false. We continue to treat people through death. We treat death. We treat the end of life. We give medicines and we do things to make people comfortable. So that's one thing, is that it's not set in stone. There's no reason to be afraid of this, and it can change. The other thing is that, to me, this is the patient's voice. There are many times where, I loved how Eric mentioned, where one or two family members who may be out of state or elsewhere come and visit or are now in the picture of family discussions and are not on the same page with the prior discussion that the patient may have had. It happens commonly, and it is so time-consuming. And sometimes it's not Uncle Bob or Aunt Jeannie or whomever. It's many times between siblings. There's a sister here or brother there, and things are not totally connected. I think that as we grow, our relationships with those we love change, and that's okay. But what this does for me as a hospitalist is when I look at who the medical durable power of attorney is, I'm able to really know that this patient who signed this, filled it out, talked about it with their provider, designated this person as their voice. So all of the stuff that's going on around me, and there can be a lot with a lot of differing opinions, if I know who the medical durable power of attorney is and the patient still has capacity, I'm always going to talk to the patient no matter what. But I also look at the medical durable power of attorney, realizing that within these discussions, it's the voice of the patient or the medical durable power of attorney that I really need to hear and really listen to, and kind of direct things that way. So that's the second thing, is the voice. And then the third thing was just to let everyone know that the medical durable power of attorney is on here. I've had some people, employees, who have gone through filling out medical durable power of attorneys and say, well, I wouldn't have my husband or father or a relative fill out another form because we already did it. We already filled out the Colorado Health Association medical durable power of attorney. And while that can happen, as long as please put the same name. This most form has a medical durable power of attorney on it. So you can have a patient fill out a most form even if they've told you, well, I've already done a medical durable power of attorney with a lawyer or something like that. So those are my 3 things.
Take the baton from there because I also work in the hospital setting. Again, I also want to appreciate Peggy Budai and the Health District for putting this together. I have the privilege of working next to Peggy every single day. And whereas in palliative care, we often describe ourselves as an extra layer of support for patients, families, Peggy and her work in the community is an extra invaluable layer of support for us. So thank you, Peggy, and the whole team for inviting all of us to come up here and allowing me to represent the palliative care lens. I wanted to share just a little bit about the things that are important for me that you know, and since I have this platform, I wanted to talk a little bit about what palliative care is. My background is as an oncology and bone marrow transplant nurse for about 9 years. I worked as a traveling nurse, so I had this vantage point of looking at how different hospital systems did things across the country and internationally. And that really kind of led me into pursuing an advanced practice degree and working towards a palliative care focus. I kind of always understood palliative care as a human rights issue and thought about my sort of platform in nursing and how palliative care was a fit, caring, thinking outside the box, care along the continuum, and building relationships. So for me, it was kind of a natural fit before I understood the definition of palliative care. So the first thing I want to make sure that everybody understands is what it is. It's a barrier that we kind of come into every day. People often associate palliative care with hospice or end-of-life care. And so it's an opportunity and consultation that our team kind of presents what palliative care is. We are part of a larger network of palliative care providers up in the northern Colorado region. There are palliative care teams at Banner, there are palliative care teams that provide outpatient palliative care. And our team really started 4 years ago at UC Health as a one-woman nurse practitioner sort of initiative and has grown now to 7 providers. We have a new provider out in the audience today that's starting with our team. So palliative care it's a medical subspecialty. Our focus is on quality of life and helping really explore and define that with patients and families. We do that in a lot of different ways. We tend to have a little bit of time. As you mentioned, we have the benefit of time working with people, and often an initial consult for us in the hospital will be 1 to 2 hours, where we can go in and introduce ourselves to families as that extra layer of support that was invited in from their primary medical team to help explore things and explore what are our goals of care. Talk about advanced care planning and talk about symptom burden. And sometimes we're there just for emotional support. We're good listeners on my team, and we're there to provide that kind of support. Palliative care is different than end-of-life care, but certainly does promote that dying is a normal kind of part of the life cycle, and we try and support peace and dignity at the end of life. But palliative care is different in the fact that we sort of walk alongside medical teams and provide care at the same time. So our team works as an extra layer of support to the primary medical team and helps provide care and recommendations along with the oncologists, along with the cardiologist and neurology group. And it's pretty interesting because the outcomes have really shown that good comprehensive palliative care in a community can improve outcomes for quality of life and actually improve survival in some cases. So the word is out. There was a landmark study in 2010 by Dr. Jennifer Timmel that looked at patients with non-small cell lung cancer receiving their cancer treatment and palliative care, and it really did show that people have longer survival and better quality of life. So Whereas it's pretty new up in our community, it's sort of catching on across the nation, and really, truly, palliative care is the expectation and the norm in most hospital settings. 80% of hospitals have palliative care teams. So when we're involved in patients' care, as it relates to the discussion today, we spend a lot of time on advanced care planning and looking through the MOST form, looking through documents, and trying to get all those documents together, have these robust conversations, and then translate that conversation into either an updated document or completion of a MOST form or an advance directive of some sort. I think the piece to my job that I'm most humbled by every day is the ability to really talk about fears, talk about hopes, educate patients and families. As a nurse, it's a really natural role for me as a nurse practitioner. It's something I'm comfortable with, sort of talking about, what are the outcomes that we expect? What does that mean to you in your life? Excuse me, today, and what's important for you tomorrow. And everybody has a different answer to that. So it's always a privilege for us to be involved in care and then to hand the baton back into the community. Before I worked for UC Health, I worked for a program called Optum. I don't know if anyone's familiar with Optum, but it's a nurse practitioner-driven benefit through United Healthcare. Again, the idea there was to provide extra support to residents in nursing homes and long-term care facilities. And a lot of the palliative care principles sort of jive with what we do now. So I'm happy to be part of this discussion because I feel like I've had my feet in both doors, in the community and in the hospital setting. And we're open and hopeful to continue having good conversations on how to improve continuity of care from the emergency room to coordinating work with the hospitalists and then handing that care off back into the community. So the other thing that I just want to really share with you is that your work matters. The work that's being done in the community, the conversations that you're having those in-depth conversations with patients and families, including medical decision makers, including support systems, and asking about them. That work, when people come in crisis mode and they come to the hospital through the ED or they're in the ICU and palliative care is consulted when the patient's unable to really meaningfully interact and we're trying to make some really serious decisions, we go back and we reflect on those documents and we talk about, is this a valid document? Who was involved in the conversation? And we'll often reach out to the PCPs and try to glean more insight from the community so that can help us support sometimes the complicated situations that we get into with families, medical teams, everybody having different opinions about non-beneficial care versus, what are the goals and values of the patient. So I humbly appreciate all the work that's going on in the community, and I appreciate your willingness to come here and learn more about the steps to continue these conversations. We run into barriers at times where we have forms that are incomplete, or we did this form 5 years ago and now last month Dad had this conversation with me, now he's in the ICU, different opinions. But at the basis, it's seeking understanding, having robust conversations, and then using these forms, again, to document that conversation. So, thank you.
All right, and so I'll finish up. And for me, over the last, I did a family medicine residency, so I got a brief glimpse of what life in the ER is like. And then I also worked as a hospitalist before I went back to fellowship. And so now I'm on the other end of things, more back in the primary care role. And I would really advocate that I think primary care is where the conversation has to start. It's really hard when you're in those other roles to have that in that crisis moment because people, they're coming from a place of fear, they're going to lose their loved one. So having those conversations early on are super important. I did have the privilege of working with associates, and I think they've done a great job. And some of their providers have known these patients for decades. So if you have that relationship with someone, to have that conversation, have it frequently and often. If they, at a minimum every year when they have their Medicare wellness exam, but if they're hospitalized, you should or have a new diagnosis, just definitely readdress it and touch base with that patient to make sure that you're still doing the things that they wanted. The other thoughts I had was similar to what they already said about DNR. does not mean do not treat. And I think that is a very important thing to distinguish for patients, because they do make that assumption that you're just going to pull the plug if you are a DNR. And the Pulse Paradigm had done research based on that registry that I talked about. And in that first year, they had about 25,000 patients on the registry. About 72% were DNR, and only 50% of those were comfort measures. So you can never use that DNR as well to make assumptions about what the care people want to. Just because they're DNR doesn't mean that they don't want treatment. And really, there's no, I mean, if you're a provider, if you're a nurse practitioner, a PA, or a physician, you can bill for this now. So they are reimbursing for it. So there's really no reason not to, because you will, they do incentivize your time now. And there are codes for that. If anybody's interested in that, I'm happy to share that with you later. And then I had a few more thoughts on the form, since I kind of got to already share some of my other thoughts with you. On Part B, if you look at it, at the bottom there's, for medical interventions, there's something, that little line that says additional orders. And I frequently use that as an opportunity to talk to patients, especially with end-stage renal disease, about dialysis too, because that's a big procedure as well. So you can write in things that you don't want to have done if you have a chronic medical illness, and that is certainly one of them. So I use that as kind of an opportunity to talk about that. And I find too, sometimes starting with Section B is easier than kind of talking about code status. I think sometimes focusing on that DNR issue really distracts from the bigger picture. So if you talk about Part B and they say, well, I'm never going back to the ICU, then you can say, well, we probably shouldn't make you a full code. So sometimes it makes that Section A a lot easier if you're starting with Section B. And then my last thing is, Peggy kind of touched on it with the handout that you guys have about artificial nutrition. It's, paternalism in medicine is kind of frowned upon, but especially in the setting of advanced dementia, I am very paternalistic about the artificial nutrition section. And the AGS, American Geriatric Society, did put out their white paper in 2013, and it's not recommended. It just isn't. In advanced dementia, there is no place for feeding tubes. They have shown that hand feeding is just as good as any tube feeding that we can do, and that's what facilities provide. If they're living in a long-term care facility, they have assist tables where people help them eat. So they do get careful hand feeding, and the outcomes are just as good for death, aspiration, pneumonia, and function and comfort. And I do try to warn people that those feeding tubes are kind of like a tether for people that have dementia. It causes increased agitation, and that puts your loved one at risk for having chemical and physical restraints used, right? Because they're gonna not be able to verbalize what they're having trouble with, or that they're having discomfort from this feeding tube, and they're gonna act out, and it might result in further medications that we don't want that cause increased morbidity. So I really try to have a firm conversation about that in the setting of dementia, because once you put those feeding tubes in, they're near impossible to take out, and you have to have two doctors. One of them has to be a neurologist, and there's all these requirements for that. In a POA, and it's really important to look at your past directives. Like, we've already emphasized that many times, but if there is a living will, and it says that they are okay with artificial nutrition, a POA can't step in and say that they can't say no at that point. So you have to make sure that when you're filling this out, that the past stuff is consistent with that. So that's, from my perspective as a geriatrician, I tend to be a little bit more paternalistic and try to help guide people, because it's not like they've navigated this before. And I just have seen enough of the bad outcomes that I really try to help people work through that. But that's about it for me, because I already got to say a lot.